Dr. Wallace. I wanted to record a quick lecture for you for Chapter 27, Hematologic Disorders. A lot of this is just going to be a review of the patho as far as, all of the different elements of the blood. And then we're going to talk a lot about anemias. And then a lot of these disorders you've heard about or seen. And many times it's a disorder that has begun in childhood and then carried over into adulthood that we see more of the physiological changes once they're adults. So we'll go ahead and get started on this. Like I said, it will probably go pretty quickly, even though it is about 70 something slides. So your A&P review, just remember that your cellular components of your blood all have specific functions. So your fluid component is your plasma, which is your transport medium. Your erythrocytes are your red blood cells, leukocytes are your white blood cells, and your thrombocytes are your platelets. Your erythrocytes, the production is regulated by erythropoietin, and the red blood cell production requires iron, vitamin B12, folic acid, amino acids, and other nutrients. As the red blood cells differentiate, their nucleus is replaced by hemoglobin, and they have a characteristic biconcave disc shape. Your reticulocytes, which are your youngest red blood cells, that count reflects your erythropoiesis rate. So if it's high, then that means that we have some reason that your body is producing lots and lots and lots of brand new red blood cells. If it's low, then maybe there's some production issue where there's a depression in the production. And then a normal life cycle for a mature red blood cell is about 120 days. And so, in some conditions, we may see a shortened lifespan, and then in some conditions, we may see that over that 120 days, we're not producing enough every 120 days. Your hemoglobin is the oxygen-carrying molecule of the red blood cell. Production requires circulating iron, synthesis of the protoporphyrin ring, and production of globin. The iron atoms in hemoglobin combine reversibly with oxygen to form oxyhemoglobin, and the percentage of oxyhemoglobin is what we consider your arterial oxygen saturation. With your erythrocyte development, we've already talked about those dietary elements that are necessary. So your iron, your folic acid, your B12. And then your reticuloendothelial system is in your spleen, liver, and bone marrow. Structural variations. Hemoglobin molecules composed of two subunit chains, so they're either alpha or beta, and there should be equal numbers for normal cell function. There are various forms of hemoglobin when we look at embryos, fetuses, and adults. So we have hemoglobin F, which is the fetal hemoglobin, hemoglobin A, which is the adult hemoglobin, hemoglobin A2, which is a mutation we see in beta thalassemia, and hemoglobin S that we see in sickle hemoglobin. Normal values, hemoglobin increases with increased gestational age. We would see a physiological drop when a baby is about 2 to 4 months old if they were term. If they were premature, then we see it at around 6 weeks. And the reason we see that is, as it says above, that hemoglobin increases the longer that baby gestates. So the further along in the pregnancy mom is, the more hemoglobin the baby gets from mom. And so those fetal hemoglobin stores are increased the longer that the baby gestates. So if we have a premature infant, they don't have as much time to accumulate that fetal hemoglobin. And so that's why we would see that physiological drop earlier in premature infants. So that's going to put them at a higher risk for anemia. Anemia is going to be characterized on basis of the red blood cell size and the appearance. And when we talk about these anemias and all of these conditions, we'll talk about microcytic, macrocytic, hypochromic, and that's talking about, are the red blood cells small? Are they big? Are they pale? So do they not have as much hemoglobin? You know, what are the characteristics of the red blood cell that actually lead to whatever deficiency we have related to that specific anemia? Antigenic properties of your red blood cells, just keep in mind that your red blood cells are where we look at that ABO factor. So, what is our blood type? And then, are we Rh positive or are we Rh negative? Leukocytes, these protect your body from invasion by foreign organisms, and they help distribute antibodies. If we have a white blood cell count less than 500, they're at risk for fatal infection. If they have a white blood cell count of greater than 30,000, that indicates that they've got a massive infection or possibly leukemia. Keep in mind that your granulocytes, when we start talking about granulocytes and agranulocytes, your granulocytes are your neutrophils, eosinophils, and basophils, and your agranulocytes are your lymphocytes and your monocytes. Neutrophils, their major function is phagocytosis, and they are the primary white blood cell in fighting bacterial infections. And we will see if we see a relative increase in the number of circulating immature neutrophils, so that's when we would see bands, then that's when we would have that shift to the left. In basophils, these are closely related to tissue mast cells, and they release heparin and histamine when a person has an allergic reaction. And then the eosinophils immediately release histamine and destroy parasites. Lymphocytes originate in your bone marrow. They differentiate in lymphoid tissues, and that's going to be your spleen, liver, thymus, lymph nodes, and intestines. These include your T cells, which are included in your cell-mediated responses, and your B cells, which are precursors of a humoral response. Monocytes are relatively immature cells, and they migrate to tissues. In their mature form, they are macrophages, and their primary function, again, is going to be phagocytosis. These would be elevated in collagen vascular diseases, Hodgkin's disease, non-Hodgkin lymphoma, and chronic infestations. Platelet counts and coag factors. Um, these are essential to hemostasis and clot formation. They are fragments of megakaryocytes. Your normal platelet count should be between 150,000 to 450,000. Degradation of platelets is when we have that cascading sequence of proteolytic enzymes in the clotting process. And just remember the prothrombin, thrombin, fibrinogen, and fibrin are your components responsible for your clotting process. When we're looking at the anemias, remember, and I've kind of already talked about this, that we're going to look and we're going to classify based on red blood cell um, size, shape, all of the characteristics of the red blood cell. And so, but we also break it down by all of these hematologic disorders are classified by red blood cell function, white blood cell function, or platelet or coag function. So when we are assessing in relation to disorders of erythrocytes, we're going to make sure that we get a really good history, because a lot of times our history is going to clue us in as to maybe what we're looking for if we're concerned about a hematologic disorder. So we definitely look at our genetic history. We look at our ethnicity and race, because we're concerned about things like sickle cell and beta thalassemia. We're going to look at family medical history, because obviously a lot of these are hereditary. We're going to look at the child's medical history because, again, prematurity is a big risk factor for anemia. Environmental exposures, lead, we're really worried about lead. So have they been exposed to lead in some way? Have they been exposed in an older home? Have they been exposed other ways? Have they been exposed to other environmental factors that can affect them? So we definitely look at those. Chronic illness. Do they have persistent pallor? Because that may be a sign of anemia. Jaundice may be a sign that the red blood cells are breaking down more quickly than they should. Have they had any unusual blood loss? Maybe they have a clotting disorder. Any petechiae or easy bruising, then we would consider, again, some bleeding disorders. We're going to do nutritional screening because we're concerned about are they taking in enough nutritional iron? So again, with our anemias. And then newborn screening is going to catch a lot of these hematologic disorders that are considered genetic. Physical examination, we're going to look at their vital signs and their growth. We're going to look for pallor and jaundice, any petechiae, retinal hemorrhages, excessive bruising, bleeding from their mucous membranes, any lymphadenopathy, frontal bossing, joint and extremity pain, heart murmurs, hepatomegaly or splenomegaly, and congenital anomalies. Pancytopenia is going to be a decrease in all three formed elements. So this is a production failure that we would consider aplastic anemia. If it's in relation to sequestration, that would be hypersplenism. And this is may also be associated with just an increased peripheral destruction of all the mature cells. So this would be a decrease in your red blood cells, white blood cells, and your platelets. So let's talk about erythrocyte disorders. The first thing we're going to talk about is probably the most common thing you're going to see is anemia. And this is a reduction in the circulating red blood cells. And it could be due to a decreased production, abnormalities of the red blood cell, a shortened life of the red blood cell, or red blood cell destruction. Some types are more common in specific races and regions. Nutritional deficiencies, toxic ingestions may cause anemia. So if they're not taking in enough iron, or if they have somehow overdosed on iron or other elements. Anemia is going to stress your cardiovascular system, obviously, and then also your respiratory system, because if there's not enough red blood cells carrying hemoglobin, then that's going to affect our oxygenation. The majority of children that have anemia are asymptomatic. And then table 27.6 on page 636 in your book talks about the assessment of the red blood cell size and shape to help with diagnosis of anemia. And it tells you, like based on the history, physical findings, what you would expect to see as far as your results on your screening test, diagnostic studies, and how you would treat those. So when we're looking at anemia in children, about 90% of the anemias that we see in children are going to be iron deficiency anemia, lead poisoning, infection, or some sort of hemoglobinopathy. When we're looking at iron deficiency anemia or lead poisoning, that's going to cause a reduction in the hemoglobin available for nutrient transport in the red blood cells. And then if we have inadequate red blood cell production, this can be acquired or constitutional. And then at table 27-7 on page 638 in your book talks about what you would see in the history, the physical findings, and your laboratory diagnosis of the most common red blood cell anemias. And it gives you those treatment options. If we have a hypoproliferative anemia, this is a failure in the erythrocyte marrow production. So just keep that in mind as well. And you can see up here at the top is figure 27-5, which is the classification of anemia by underlying erythrocyte disorder. So this looks at if we have a hemoglobin of less than 12, so basically a hemoglobin less than 12, we're going to diagnose with anemia. But we need to determine what type of anemia are we looking at. So if we have a normal red blood cell, so we're going to look at that red blood cell, the characteristics. So do we have a normal red blood cell? Do we have a macrocytic or a normocytic red blood cell? So we're going to look at that. If we have normal and our retic count is less than 2, then we may have some hypoproliferation. So we may have some aplastic marrow, iron deficiency, or decreased marrow. If we have a macrocytic red blood cell, and again that retic count is less than 2, then we're looking at issues with maturation. And so we may have some cytoplastic defects like thalassemias or iron deficiency. And then if we have a normocytic red blood cell, but our retic count is greater than 3 to 5, then we're looking at hemolytic issues. So do we have an acute blood loss? Have they had some hemolysis due to IVs? And do they maybe have some autoimmune disorders? So that's a really good diagram there to kind of help you differentiate between the different types of anemias based on your lab findings. Given we're looking at anemia, usually our iron deficiency anemia is going to be the most common that we're going to see, especially in the pediatric population. Keep in mind, alpha thalassemia is going to be genetic. When we're doing our workup for anemia, we're going to get a hematocrit and hemoglobin screening, a CBC with red blood cell indices and morphology, because again, we want to see what those red blood cells look like. And we're going to get a retic count and do a peripheral smear. Box 27-1 on page 640 talks about erythrocyte morphology and the associated disorders. So based on what we're seeing on that peripheral smear when we're doing that red blood cell morphology, if we're seeing sickle cells, then we would know that we're looking at sickle cell disease or a hemoglobin S thalassemia. If we see a teardrop, if we see teardrop-shaped red blood cells, then we may be looking at severe hemolytic anemia or erythroleukemia. So based on what we see in those red blood cells, again, the characteristics of those red blood cells are how we differentiate the different types of disorders. Follow-up labs make sure that if we are diagnosing a patient with anemia that we are following up, because we want to see, are our treatments working? And they may not require lifelong treatment depending on their type of condition, especially with iron deficiency anemia. Usually we can do some short-term treatment, and then once it has been corrected and we work on nutritional management, then usually we can kind of phase out that elemental iron that we would supplement with. And so table 27-8 in your book talks about the different microcytic anemias and how we would need to follow up with those labs. So for microcytic anemias, these are a defect in the hemoglobin or the globin synthesis. With this, we see decreased iron delivery to the marrow, so that can result in chronic inflammation, plumbism, and iron deficiency. And then if we have a globin chain synthesis defect, then that would be when we would see thalassemia. Iron deficiency anemia, this is the most common nutritional disorder in the world. Prevalence is higher in Black or Hispanic children. Childhood obesity is a common risk factor for this because, again, if they're not getting that iron in their food, then they are more likely to become anemic. And so with childhood obesity, many times the quality of the food that they're eating that would result in that obesity it's going to be low in iron. So again, prematurity, we talked about that physiological drop happening earlier in premature infants because they don't have as much time to build up those fetal hemoglobin stores. And then again, low birth weight as well. Iron deficiency anemia does have some correlation with rapid growth. So if you think about a child, there are growth spurts in children from newborn on up until usually around adolescence. They'll have their final growth spurt. So during those growth spurt times, your metabolism increases, and so many times they don't eat enough to keep up with their increased metabolic demands, and so they may experience some iron deficiency anemia in those growth spurt times as well. And again, if they're eating a low iron diet, then that's going to be a contributing factor. Sometimes we have some patients that have malabsorption issues, so they're not absorbing the iron, and so we may see that in Crohn's, giardiasis, celiac disease, or if they've had a resection of their small intestine for one reason or another. We're going to do a universal screening for hemoglobin at 12 months, along with the assessment risk factors, and more frequently if they're at risk. I do know some providers that will go ahead and do the initial finger stick at around 9 months. And the reason they will do that is because if they're breastfed, we should be supplementing with some sort of iron elements, usually around 4 to 6 months of age, because again, we're going to usually see that physiological drop around 4 months. And then if they're bottle fed and they're getting formula, then we would usually not really push an iron supplementation because they're already getting it in their formula. However, at 6 months, they start taking solids, and that's the recommendation is at 6 months. American Academy of Pediatrics a few years ago was okay with 4 months, and now they've kind of bumped back up to 6 months. And a lot of it has to do with the fact that they were seeing an increase in iron deficiency anemia in those older infants, so in those 6 to 12 months olds, because at 4 months they started taking more solids and less formula and breast milk. So I do know some providers will go ahead and at 9 months they'll go ahead and do a finger stick just to check to make sure that hemoglobin, hematocrit, and everything looks okay. The minimum laboratory screening for this should be your hemoglobin, but your CBC is going to provide information about your red blood cells, and then we would look at ferritin as an acute phase reactant. The effects of iron deficiency, we may see possible cognitive defects, increased absorption of lead. Clinical findings in the history, we're usually going to hear reports that they're irritable, restlessness, pica, so they may eat odd things, and usually if they have pica, it's an indication that their body is needing something. It's usually a pretty good indication of iron deficiency anemia. Many times we'll hear that they don't eat well and they'll have a hemoglobin of less than 8. We may also see, again, developmental delays and some social emotional disturbances. Clinical findings on the physical examination, they may be pale. They may have tachycardia, murmurs, and signs of CHF. And if we have a patient that is severely anemic, we want to go ahead and test the stool to make sure that they don't have some bleeding somewhere. Diagnostic studies, again, we're going to check the hemoglobin hematocrit. If we have an iron deficiency anemia, that's going to be likely if the hemoglobin is low, so between 8 and 11. If they have low iron intake and there's no other cause that's likely. Mild to moderate would be considered between 7 to 10. If it's less than 7, we want to go ahead and consider a hematology consult. But if it's less than 4, we absolutely send them on to the hematologist. Your RDW result is your earliest marker of iron deficiency anemia. And their serum ferritin will be low, and this is a comorbidity with lead poisoning. Typical profile in iron deficiency anemia, we're going to see microcytic hypochromic red blood cells. We're going to see a low to normal MCV and a low to normal red blood cell number. We're going to see a high RDW, low ferritin, a high TIBC, so that is your total iron binding, and their Mentor index is going to be greater than 13. Your differential diagnosis, we're going to be concerned about other microcytic hypochromic anemias, so lead poisoning, thalassemia minor, chronic disease, hereditary sideroblastic anemia. If there is no response to iron therapy in 1 month, so we diagnose the child with iron deficiency anemia and we put them on some elemental iron replacement, and we're going to bring them back in 1 month, and we're going to do a CBC and DIF and check everything, make sure that they're at least improving. We don't expect it to be, completely up to par in a month, but we expect there to be some improvement. And so if they don't have any improvement in that first month, then we're going to do a further workup because there's probably something else going on. So we would look at the CBC and DIF. We would look at our plate counts, our RBC indices, and our retic count. And we would also check them. We would be worried about occult blood loss, would definitely be in our differential. Management, like I've said a couple of times already, we're going to do some iron supplementation with ferrous sulfate. We can do 4 to 6 milligrams per kilogram per day of elemental iron in 2 to 3 doses, or we can do 3 milligrams per kilogram per day in 1 to 2 doses. We're going to reassess the hemoglobin and hematocrit in 4 weeks. If they have a response to the iron, then great. Then we're going to keep them on that elemental iron, and we're going to recheck them again in a couple of months. If they don't, then again we're going to do a further workup and possibly refer them to hematology. And then again, we're going to continue those iron supplements for about 2 to 3 months. Iron requirements, if we have an exclusively breastfed infant, we're going to give them iron of 1 milligram per kilogram per day starting at about 4 months, and we want to avoid whole milk until after 12 months. Complications, obviously we always worry about adherence issues on any medication that's going to have to be given on a daily basis, and we want to refer those with extremely low hemoglobin, hypotension, signs of CHF, or other blood dyscrasias. We're going to send them to a hematologist. Patient and family education, we want to educate them to increase iron-rich foods. Iron supplementation for exclusively breastfed infants starting at 4 months. Avoid whole cow's milk until 12 months. Goat's milk lacks adequate iron and folic acid. Avoid giving iron with milk because that's going to decrease absorption. However, vitamin C enhances absorption. And go ahead and remember to give the family the heads up that the stool will be black. And we want to keep that medication away from children because just as much as we're worried about them being iron deficient, we are also worried about iron overdose. So we want to make sure that we keep that away from children. So now we're going to talk about our thalassemias. So the first we're going to talk about is just general thalassemia, and then we'll break it down by types. So this is a hereditary hypochromic anemia, and it's associated with the absence or decreased synthesis of normal hemoglobin polypeptide chains. Usually this onset of anemia is seen before 3 to 6 months, and there would be a family history of anemia, miscarriage, jaundice, gallstones, and splenomegaly. So our alpha thalassemia, there's going to be several variant hemoglobins, and we're going to see gene deletions of the alpha globin. If they have homozygous hemoglobin type, then that's when we see hydrops fatalis, and that is incompatible with life. If they have homozygous hemoglobin H, that is going to be that microcytic hypochromic thalassemia. So that would be hemolytic anemia, hepatosplenomegaly, and mild jaundice. Management for this, they would require some occasional transfusion during hemolytic and aplastic crises. Beta thalassemia minor or minima, this is a mild hypochromic microcytic anemia. Hemoglobin levels between 2 to 3. Must be monitored for iron accumulation, and they are usually asymptomatic. They may have some mild pallor and splenomegaly, and there's no specific treatment needed for this one. With our beta thalassemia intermediate, then they may be having some symptoms that are mild to severe. And then with your beta thalassemia major, this is more severe. These symptoms present in the first year of life. We're definitely going to send these kids to a hematologist. They're going to require transfusions. They may require a splenectomy. They may require stem cell transplants, iron chelation therapy, and if it's untreated, they're going to have bone marrow expansion. So that's going to lead to that frontal bossing, maxillary overgrowth, and osteopenia. Megaloblastic anemias. These are oval macrocytes and hypersegmented PMNs. This can be due to a lack of folic acid and or B12. Their diet may lack folic acid and or vitamin B12, or their intrinsic factor for absorption in their stomach may be absent. History, usually we're going to see this in kids that have had powdered cow's milk or goat's milk, those with strict vegetarian diets, or if they have tapeworm infestation. These kids are going to be irritable, they're going to have inadequate weight gain, and reports of chronic diarrhea. Megaloblastic anemias, we may see weakness, pallor, beefy red, smooth, sore mouth and tongue. They're going to have an elevated MCV, nucleated red blood cells, normal white blood cells, and platelets. Management, we're going to again consult with a pediatric hematologist, and we're going to do dietary supplementation to correct whatever the underlying disorder is. In your normocytic anemias, we're going to see a red blood cell size that's normal, and these usually coincide with a chronic illness, or we may see it in B12 deficiency, traumatic blood loss, or pregnancy, and these are not common in children. Transient erythroblastopenia of childhood. This is a benign disorder. With this, we see anemia, reticulocytopenia, erythroid hypoplasia of the bone marrow. This frequently follows viral infections and is associated with temporary failure of erythropoiesis. So this is going to be temporary. Anytime you see transient anything, that means that it comes and goes, and there's no specific reason usually. This is going to occur in previously healthy children between 6 months and 3 years old. On Physical examination in these kids, we see anemia and they have a gradually increasing pallor. Um, that we're going to see decreased energy levels and fatigue, association with fever, malaise, lethargy, abdominal pain, or upper respiratory infections, and jaundice may occur with this as well. Um, Diagnostic studies, our hemoglobin is going to be as low as 2.4, and they're going to have a markedly low reticulocyte count. MCV and white blood cells are going to be normal, platelets are going to be normal or elevated. And we will usually see a high serum iron level and erythroid hypoplasia of the bone marrow aspiration. Your differential diagnosis with TEC, we're going to be concerned with congenital hypoplastic anemia, Diamond-Blackfan syndrome, or iron deficiency anemia. Your management, again, this is usually a self-limited disorder, usually lasts about a month or two. No specific treatment. If it's severe, then we may do a transfusion, and depending on their levels and need for transfusion, then we may refer them to a hematologist. Hemolytic anemia, this is premature destruction of the red blood cells, and that causes an increased production of reticulocytes. This can be hereditary or acquired. What we're going to see in this is elevated reticulocytes in absence of bleeding or heparin therapy. So if we had bleeding or we were doing heparin therapy on our patient, then we would expect to see some increased production of red blood cells because we're needing to replace red blood cells. But if we're not doing those things, then we're still producing those immature red blood cells at a very fast pace, then there's something else going on. And we're going to do a careful history to determine the etiology. We're going to do, as far as our labs, a hemoglobin electrophoresis, a Heinz body stain, and an osmotic fragility test to diagnose this. Sickle cell anemia and trait. This is a group of complex chronic disorders. With this, we see hemolysis, unpredictable acute complications, and possible organ damage. Children with homozygous inheritance have sickle cell disease, and they synthesize hemoglobin S instead of hemoglobin A. Hemoglobin S comes out of solution to a low PaO2, and that causes sickling. And then those sickled cells clog small blood vessels, and that causes ischemia, pain, and other vaso-occlusive problems. This is an autosomal recessive disorder, and we see it mostly in those of African descent, including also those Mediterranean, Caribbean, Central and South America, and India. And we will usually see this on our newborn screens. Clinical findings, if they are heterozygous and have hemoglobin A plus hemoglobin S, then that means that they have the trait, not the disease. They may become symptomatic with hypoxia and have a higher increase in sudden death with the disease, not the trait. With this, we're going to see multi-system symptoms. So we're going to see fatigue and anemia, pain crises because we have that sickling, so it's going to affect the blood flow. Dactylitis and arthritis, bacterial infections, lung and heart injury. So if you think about those sickled cells getting clogged in the vasculature. We may see leg ulcers, priapism, splenic sequestration, aseptic necrosis or bone infarcts, eye damage, and abdominal pain. Physical examination. Symptoms are going to emerge in the first 6 months of life. They may have, again, those painful vaso-occlusive crises. Splenomegaly disappears after 5 years from autoinfarction of the organ, and their height and weight is going to slow after 7 years. And puberty will usually be delayed by 3 to 4 years. Diagnostic studies, we may see a hematocrit of 20% to 29%. Hemoglobin of 6 to 10. Reticulocyte count is going to be elevated between 5 to 15%. Normal to increased white blood cells and platelets. MCV will be greater than 80. MCHC will be greater than 37. Hemoglobin electrophoresis, we're going to see a predominance of hemoglobin S, and these are going to be irreversible sickled cells. Differential diagnosis, and we're going to consider chronic hemolytic anemias, hemoglobin sickle cell disease, and a combination hemoglobin S and thalassemias. Management, we are going to refer these kids to the pediatric hematologist. NIH expert panel evidence-based guidelines. We're going to follow those diagnostic and management guidelines, and then we're going to provide regular primary care services. Management, we want to definitely teach them about hydration, illness prevention, and pain management. We're going to do CBCs and reticulocyte counts every few months. We're going to make sure that they get all of their immunizations, because if they get an illness, that increases the likelihood that they are going to have a vaso-occlusive crisis. Folic acid supplementation for healthy red blood cells, aggressive treatment of infections, treatment of coexisting problems associated with hypoxia, hydroxyurea for severe sickle cell, and we're going to do annual stroke prevention screenings of major intracranial vessels. Emergency admission and referral is going to be necessary if we have a sickle cell patient has a fever of greater than 101, if they have pneumonia, chest pain, or other pulmonary symptoms, if they are experiencing sequestration crisis, aplastic crisis, severe pain crisis, if they're having an unusual headache or visual disturbances, priapism, or if they have a chronic sequela of persistent bone pain, leg ulcers, pregnancy, or contraception. Complications, we may see functional asplenia, and this is the greatest concern when they have a febrile illness. Pneumococcal sepsis may occur, and with that we want to investigate all fever, poor feeding, lethargy, and irritability. Hemolysis may occur, and that's going to result in anemia, jaundice, cholelithiasis, and delayed growth and puberty. And then if they may have a vaso-occlusive ischemia crisis, and that is going to lead to acute or chronic injury to any organ system. So the top is a image that kind of discusses how the sickle cell trait is passed on. So if we have a unaffected father, or it could go either way with the parents, honestly. So if we have one parent that is unaffected and one parent that has the trait, then we're going to have 2 out of 4 children that would have the trait. If we have if we have 2 parents that have the trait, then we're going to have 2 children out of 4 that are going to have the trait, and one that's actually going to have sickle cell. Patient family education. This is absolutely going to be a partnership with the family and providers, because this is a lifelong disease. We're going to make sure that they get their routine immunizations, they're taking their prophylactic antibiotics correctly, genetic counseling, because as we've talked about, this is hereditary, support groups for other families that are dealing with sickle cell. We want to educate the adolescents with the trait, and again, this kind of comes back to that genetic counseling. They need to be aware that they have the trait and what it means for them health-wise and how to take care of themselves once they become adults. But also they need to keep that in mind as far as when they're making decisions about having children. They may require stem cell transplants and gene therapy. a hemolytic anemia, and it results from a deficiency of spectrin, which reduces red blood cell surface area. And what we will see is the red blood cells are more spherical and they're more likely to be sequestered and prematurely destroyed. So you can see in this picture down to the right what our red blood cells should look like. And then you can see the black and white picture over in the very bottom right hand corner, how these are more spherical. They're not really as concave and flat. Mild chronic hemolysis to severe transfusion-dependent anemia is what we're going to see. Clinical findings, jaundice in the newborn period, and that's because those red blood cells are being prematurely destroyed. So there's a high level of jaundice associated with a high level of red blood cell destruction. And we will usually have some splenomegaly after about 2 years. Diagnostic studies will see a chronic anemia. The reticulocyte count is going to be from 5 to 20%. A small proportion of the red blood cells are spherical when we look at them on a smear. Osmotic fragility of cells is going to be increased, and the prenatal and carrier testing has limited availability. Management, if we have a patient that's requiring frequent transfusions, they may need a splenectomy. We're going to make sure that they get their pneumococcal and meningococcal vaccines prior to splenectomy. Prophylactic penicillin therapy is going to be required after they have their splenectomy. Complications, if they may see aplastic crises, so they may have fever, fatigue, abdominal pain, or jaundice. Infections should be vigorously treated in these patients, and they may have some gallstone formation. Glucose 6-phosphatase dehydrogenase deficiency, so usually you'll see this called G6PD deficiency. This may cause drug-induced hemolytic anemia. Symptoms associated with infections, exposure to oxidant metabolites of drugs. Clinical findings in the history, we're usually going to see if these kids have had a recent infection, or they've had some sort of oxidant drug ingestion, so aspirin, sulfonamides, antimalarials, antihelmintics, favavine. So these oxidant drugs can cause this deficiency. Clinical findings on physical examination, we may see pallor, jaundice, if it's a chronic hemolysis. If it's a drug ingestion, we may see pallor, jaundice, lethargy, irritability, headache, and red, dark urine. Diagnostic studies, we're going to do dye reduction tests, and a G6PD screening is done in a few states on the newborn screens. Management, there's no specific treatment. This is supportive treatment. And patient and family education, we want to avoid the offending foods and drugs. Now we're going to talk some about platelet and coagulation disorders. In platelet and coagulation disorders, we want to rule out these disorders in children before surgery. If they have any history of petechiae, nosebleeds, mucous membrane bleeding, and excessive bleeding with minor trauma. If there's any family history of bleeding disorders, if there's history of drug or toxin exposure, and we're going to check a CBC platelet count, PT, APTT, to differentiate between idiopathic thrombocytopenic purpura, hemophilia, von Willebrand disease, and leukemia. First thing we're going to talk about is immune or idiopathic thrombocytopenic purpura, and this is an autoimmune response that destroys circulating platelets. Usually this is going to occur after a viral illness, and most are going to resolve within 6 months with or without treatment. However, we do have those children that have chronic ITP that lasts longer than 12 months and is going to require evaluation for other disorders. So Clinical findings, the diagnosis is going to be based on symptoms, their laboratory tests, and so that's usually when your platelets are going to be less than 20,000. They have an acute onset of petechiae, purpura, and bleeding. And again, these kids have usually had a recent viral illness. They may have hemorrhage of the mucous membranes, nosebleeds, menorrhagia. Um, Usually there's not going to be any hepatosplenomegaly or lymphadenopathy, and they very rarely have bone pain or pallor. This is a picture of what the purpura look like. Diagnostic studies, we're going to see a low platelet count, less than 150,000. In severe thrombocytopenia, we would consider it severe if the platelets are less than 20,000. We're going to see a normal PT and APTT. Megathrombocytes are going to be seen on the peripheral smear. They're going to have a normal white blood cell and red blood cell count. Hemoglobin may decrease with severe bleeding. Differential diagnosis, we want to rule out hemolytic uremic syndrome, DIC, and lymphocytic anemia. Management, usually the prognosis for this is excellent because, again, usually it's kind of self-limiting. But if the platelet count is greater than 20,000 and no hemorrhage, then we just tell them to avoid contact sports, aspirin, and NSAIDs. But if the platelet count's less than 20,000, then they're usually going to get a short course of corticosteroids or IVIG if the bleeding is severe. They may require splenectomy, immunosuppressives for refractory or chronic ITP. And complications that we would see with this are intracranial hemorrhage. And so again, that's why we tell them to avoid contact sports. Hemophilia A and B, or von Willebrand's disease. This is an inherited coagulation deficiency. Factor 8 is going to be your hemophilia A, and factor 9 is your hemophilia B. Factor 8 binds with von Willebrand factor in their plasma. So if they have top 1, it's a reduced factor. Top 2 is going to be qualitatively abnormal, and top 3 is going to be absent. These are dependent on sex-linked genes, so this is an X-linked recessive disorder, and so we see this primarily in males. Figure 27-3 in your book. Let's see where. So 27-3, I'm trying to find the page number for you, and I can just not find it right this second. But it should look something like this on the left. And so to differentiate what you're going to see with the different hemophilias. So hemophilia A, you're going to have that deficiency of coag factor 8. And hemophilia B, you're going to have that deficiency of coag factor 9. Table 27-10 on page 653 in your book does give you the comparisons based on your labs between hemophilia A, B, and von Willebrand. Okay, so just so that you guys know, I paused this for just a second because I wanted to find that figure 27-3, because what it actually is on page 634, and it's way back where we were talking about the pathophysiology. So it discusses and shows you your classical coagulation cascade. So it talks about the intrinsic pathways and the extrinsic pathways. And so if we have a tissue injury, what's supposed to happen? So, we have the tissue factor, the thromboplastin, that activates. So then we have our factor 7, and then that becomes our tissue factor is 7A. That's in our extrinsic pathway. In our intrinsic pathway, we have our Hagman factor, which is 12, and that becomes 12A. Then we have our thrombin, and then it cascades down, and it interacts with our tissue factor. And so it goes all the way down the tissue, the coagulation cascade. And so it brings in, your thrombin and your prothrombin and your fibrinogen and your fibrin and your cross-linked fibrin. So that whole, that figure 27-3 on page 634, I was trying to find it in with the hemophilias, and I just couldn't find it. So I wanted to find that for you. Page 634 is that coagulation cascade. Clinical findings, there is usually, or there will be a positive family history, history of excessive bruising or prolonged bleeding, hemarthrosis, so this is where they will have bleeding into a joint with injury. We're going to see a prolonged APTT, and they're going to have a specific assay for factors 8 or 9 to confirm. Management, we want to prevent trauma because, again, we want to prevent bleeding, especially into those joint spaces because it can cause damage. We're going to replace the factor. Cold and pressure to be applied to affected joints, and we're going to do an interdisciplinary approach with the hemophilia center. Complications with this, we may see brain hemorrhage, anemia, and hypovolemic shock if they are injured and have a bleed. When we talk about replacement therapy, these parents will actually be trained to start an IV and do the replacement therapy at home if an injury occurs. Thrombophilia, this is an increased ability to form blood clots. Thrombotic events are rare in children, but those that have 2 or more inherited thrombophilia traits should be tested. And this is still something that's somewhat new in pediatrics to help these providers understand that we can have children who have thrombotic strokes. I've talked when I was in grad school, that was one of my projects, was to discuss stroke in children and the different reasons why we may see that. And I had several nurse practitioners who were teaching in our program that was like, I never knew that kids can have strokes too. And there's many different reasons why it can happen, but thrombophilia, these thrombotic events, even though it's rare in children, it doesn't mean that it can't happen. So that's just something to keep in mind. So if we have those children that have 2 or more inherited thrombophilia traits, we're definitely going to check them, and we're going to check them often to make sure that they're not at risk for a thrombotic event. Now we're going to talk a little about white blood cell disorders. With our white blood cell disorders, we're going to be looking at our white blood cell count, obviously. This is going to be our indicator of infection and illness. That's what we usually look at it for. But we're also needing to look for white blood cell dysfunction. So we may see that with infection, illness, or malignancy. So if we have alterations of our granulocytes, so we may see neutropenia, and that's going to be a decrease in the number of circulating neutrophils or bands. Mild, we may see a level between 1,000 and 1,500. Moderate, it's going to be between 500 and 1,000. Severe, it's going to be less than 500. Obviously, we may see neutropenia, severe neutropenia, if they're getting chemotherapy. Alterations of granulocytes, so lymphocytosis, are going to be produced by viral illnesses. Cancer, clinical signs and symptoms are going to be variable, non-specific. So it may be weight loss, headaches, swelling, pain, excessive bruising, bleeding, rash, infections, nausea, fatigue, or fever. So these are very non-specific, especially when you look at the pediatric population. And, infections, nausea, fatigue, fevers, that can be any virus, any infection. And so, sometimes it takes us a little bit longer to catch on that maybe it's not just general childhood illness. Um, Incidence mortality vary by race and ethnicity. Ionizing radiation is a risk factor. Leukemia, that's when we see changes in circulating leukocytes. And lymphomas are going to be solid neoplasms that are lymphocytic in nature. Leukemias, we would see normal bone marrow elements replaced by abnormal, poorly differentiated blast cells. These are classified by the cell type involvement, cellular differentiation. The most common form of childhood cancer is leukemia, with ALL accounting for 80% and AML accounting for about 15%. Clinical findings, we see repeated infections in these kids, fever, weight loss, bleeding episodes, lymphadenopathy, hepatosplenomegaly, bone and joint pain. Diagnostic studies, we're going to look at a CBC with diff, platelets, reticulocyte counts, peripheral smear. Bone marrow aspirate is going to tell us a lot, and we're going to look for chromosomal and genetic abnormalities. Management, about 90% of these kids have about a 5-year survival rate. We're going to do 4 to 6 weeks of induction chemotherapy followed by consolidation phase of several months, and then 2 to 3 years of maintenance therapy. We're going to do allogenic stem cell transplantations after a second remission. We may be able to do that. Philadelphia chromosome may be considered for stem cell transplant sooner. If they have AML, we're going to do the induction, CNS prophylaxis, and post-remission therapy. And if they have any long-term sequelae, we're usually going to see that it affects on their cognition, their neuropsychological function. They may have growth deficiencies, and they may have risk of second malignancies. Lymphomas, if we have a non-Hodgkin lymphoma, these are solid tumors of the lymphatic tissues. So it's malignant proliferation of the T cells, B cells, or intradeterminate lymphocyte cells. This is most frequently diagnosed in the second decade of life. Clinical findings, they will usually have an acute abdomen, or they have a non-tender lymph node enlargement. Diagnostic studies, we're going to do CBC, LDH, uric acid, and electrolytes. And we're going to do radiography, CT, MRI, and PET scans. Management, this again is going to be a multidisciplinary approach, and they're going to require chemotherapy. For Hodgkin's disease, this is a malignancy of the reticuloendothelial and lymphatic systems, and this involves the B cells. And these will originate in the cervical lymph nodes. Clinical findings, they have painless enlargement of their lymph nodes, chronic cough, fever, decreased appetite, weight loss of greater than 10%, and drenching night sweats. Diagnostic studies, we will usually see anemia, elevated or depressed leukocytes and platelets, ESR-CRP, elevated copper or ferritin, abnormal LFTs, proteinuria, and we would again get radiography, ultrasound, CT, MRI, and PET scans. Management, we're going to send them for treatment at a comprehensive pediatric oncology center, and they're going to have lifelong monitoring for side effects. The late effects of childhood cancers, these are going to be attributed to the radiation and chemotherapy and the effects that it has on their body. They will often have late puberty, or they'll see these effects in late puberty or with aging. They may have short stature if they've had cranial irradiation, precocious puberty, avascular necrosis of the bone due to exposure to the steroids. They may have osteoporosis, again due to the cranial irradiation or steroids. They will have, they can have leukoencephalopathy, again due to the effects of the radiation and chemotherapy, peripheral neuropathy, cognitive dysfunction, strokes, and seizures due to the intrathecal chemo, vision, auditory, or skeletal changes due to the radiation, obesity, and gonadal dysfunction is going to be considered a neuroendocrine effect. And then this just talks about all of the different things that we may see, altered puberty development, cardiomyopathy, pericardial effusion, pneumonitis, pulmonary fibrosis. Um, it's there's the possibility of lifelong, um, even if we can get them into remission and help them to survive, the likelihood that they're going to have lifelong issues is very high. So that wraps up chapter 27. If you have any questions about anything, please let me know. And I hope you guys have a great weekend. Bye.